I've been concerned for some time that in the zeal to promote the interests of trans people, that somehow we have reverted to sexual stereotypes.
Exactly.
And this is not good. This is the wrong direction. We need to be more inclusive and more accepting, and which doesn't mean giving, as you said, not giving everybody everything that they want, but to be more accepting means balancing interests, and certainly for young people, we need to balance the interests of young people in terms of what they want with what they need, and parents are in a better position in some cases to determine what a child needs than the child themselves. And to my chagrin, in America, there are some people, child advocates, who say, but children know who they are, so just give them what they want.
Yeah.
And I often ask myself, have you ever been a parent? Have you ever actually had children? Do you understand what children do?
Lytter til Snakk med Silje.
My name is Silje Schevig and I'm a clinical psychologist from Norway. In my podcast Snakk med Silje, in English Talk with Silje, we talk about different subjects concerning psychology and our society. My guest today, Dr. Erica Anderson, is my first international guest, but there will be more to come in the future. I myself am critical about gender-affirming care for children and adolescents, especially medically transitioning children through puberty blockers. I think we do more harm than good in how we deal with this issue today. Regret is a complicated concept when you deprive children of their puberty. Puberty is a sensitive period where the most important identity development takes place. A child can never know how their life would turn out if they had gone through puberty. I met Dr. Anderson at an international conference addressing gender-affirming care to children and adolescents, which is the main subject of our conversation today. Dr. Anderson is a clinical psychologist helping gender-incongruent young people and their families. In her TV career in Sweden, Erica broke barriers as the first openly trans character on prime-time TV in the series Alt for Sverige, which led to her being nominated for 2 Gay Gala Awards. She also won the award for Transgender Person of the Year. She has previously been president of WPATH, which is the US Professional Association for Transgender Health, and a board member of the World Professional Association for Transgender Health, WPATH. She has a long career that she will tell us more about. You can also learn more in the description of this episode. Welcome, Dr. Erica Anderson.
Thank you very much. It's a pleasure to be here.
Yeah, so I met you at a conference here in Norway. We were having a lot of different discussions and different experts on the field of gender-affirming care in Europe mostly, but you came in from America.
Welcome to America.
Yeah, and, so it was really interesting to hear about the difference how different things are in between Europe and America, and you have a lot of experience from America as a psychologist, and you also have a degree in theology.
Oh, you did some research?
Yes, I did. And you've been president of actually different organizations.
Yes, I have.
US PATH, amongst others. So maybe you could just tell a bit about your professional career. What you been doing, and also I would like to hear a bit about your personal history also,
of course,
because it's relevant for the field where we had a conference about.
Yes.
Yeah.
Yes. Well, as you know, I'm a clinical psychologist for many years. I've been saying 45, but it's actually 46 years. You know, I was a psychologist when I was this big. So a long time, but I've done many things in a long career as a psychologist. I was very interested in child and youth psychology when I was in training and studying, and so I was very deliberate about being trained as a child and adolescent psychologist and also as an adult psychologist. So that has served me well because in my clinical work, I've worked many different people across the lifespan. And I was a university professor, young, and trained psychology interns and did some research. And then I ended up going into practice and had a very successful private practice. And that practice ended up being a business. We had, when I finished, we had already 5 clinics, and then we also had 4, I would say, satellite operations where we were the mental health department for 4 large multi-specialty doctor groups of 50 to 80 doctors each group.
Wow.
So we were providing a lot of mental health services. We had psychologists, psychiatrists, social workers, marriage and family therapists, and I was the president. So I was running a business, and then we added another business in rehabilitation, which I also was responsible for. And I ended up leaving that organization to go to California. I was in Minnesota, for those who know it, in the middle of the North America, where a lot of Norwegian and Swedish people went many years ago, immigrated. And my family, it's Swedish, all of the sides. So that's how my ancestors ended up there. And then from that job in California, I ended up spending 20 years running healthcare companies, and I had a chance to be an executive in the health insurance field, a hospital executive, and was responsible for creating and building a number of businesses and so on. That by the time I was through the 20 years, I was older, and I'd kind of run the course, and I was kind of ready to step out of that work, and ended up doing consulting for a few years, and then felt like I could still do some teaching. So I ended up deciding to do that in conjunction with my own gender transition, since I am transgender, and I was a late transitioner by conventional standards. So had a life living as Eric, was my original name, and was married to a woman, and we had 2 children. So I'm a biological father and a parent, and I transitioned after they were basically finished with college or university, and decided that I should move to California. That would be easier for me. We had moved around the United States for my executive job, so at the point at which I moved to California, or back to California, we were living in metropolitan Philadelphia. So I moved all the way cross country.
Was it because it's more accepting in California?
And my expectation was that it would be easier because it was more accepting, that there were more trans people in California, and California is widely known to be more liberal than most places, even in the United States. And that was true, that was true. So I got a job as a university professor, and because I had management experiences, I was appointed as the chair of a department, and which had a doctoral program, And so I did that. I had a series of posts at that university and ended up as a dean. And again, we were talking earlier, and I told you I wasn't looking to be in management ever again. But they persuaded me that I could help them, and true. So then I've 3 times been a department chair or program chair in universities, and once a dean. And so I ended my career there as a professor of clinical psychology, and I ended up being recruited to the University of California, San Francisco, and their gender clinic there.
Yeah.
And I had by that time been affiliated with a number of people who were doing work in the gender area, particularly with youth. And 2 of the people I got to know were the original founders of that clinic, a pediatric endocrinologist and a clinical psychologist, and they recruited me to come as the next psychologist. So I spent a number of years there working with gender questioning and transgender youth, from young children through young adults, and that was quite an interesting experience. The youngest patient I ever saw who was gender questioning or gender variant was 4 years old.
Okay.
And I've continued. I restarted my private practice in California around the same time that I was at the University of California. So I was seeing patients in both the clinic and in my private practice. I'm going to take a sip of this wonderful coffee.
Yeah, but so 4-year-olds.
Kaffe.
Yeah, coffee. So 4-year-olds, like, what do you help like a family of a 4-year-old with? Because shouldn't they just be gender fluid and don't fuss so much about it?
Yes, I would say the same, and that has been my approach. But in this case, this young child was troubled about their gender, in part because mother and father were not agreed about how much to accept or encourage this gender variance. And the child was distressed enough, it's a little graphic, but this child tried to castrate himself with a scissors.
Okay.
Cut off his penis.
Horrible. Yeah.
So
it's really troubled.
It was very troubled.
Kid,
and so that's how they came to me, is, like, in fact, now that I'm remembering better, the family came to me, and this distress spiked within a few weeks of me seeing them, and the mother called me distressed to report what had happened to their child. And so she stopped him, she was paying attention. So that's one of the more dramatic, I guess, situations that I've been involved in. But the changes in the group of young people coming to gender clinics, which is widely reported, it's been in Norway and the Nordic countries and the UK, Western Europe, as well as in the United States and Canada, for that matter, meant that the population that we were seeing in the clinic started to shift to being more teenagers, more adolescents, and also more natal females, more girls assigned at birth, and that coincided with my experience. I was often the first contact that a family would have. I would do an initial interview with families, so it was easy to see these shifts, and one of the younger endocrinologists and I were the ones who usually saw the new patients. So I was very much in the early I guess, awareness of the diversity of presentations at gender clinics, and the new questions about, what does this mean? Who are we seeing? Do we use the same approach that we'd been using with kids who had expressed a gender variance in childhood, and whether they had come to us in childhood or at puberty or shortly thereafter? The typical presentation in gender clinics in the USA and then in Europe was natal males, and usually the gender variance was evident to other people, like parents, particularly in childhood. So that was in the early time at the university clinic. That's what I saw too. That they were mostly boys who were asserting a female gender identity and so on. But then as the population shifted, new questions came up about what do we know and not know about the different types of kids who were coming to us. So I started questioning some of the conventional thinking about what to do and whether these kids were all arriving at their identified gender in the same way. We still don't really know why does somebody become transgender, but it's been studied enough that I think the general consensus would be that it's a normal variation. A trans identity we've had transgender people throughout human history. It's well documented.
But usually in males,
but it's usually male. Yeah, it's been usually male. Although there are lots of the trans males, genetic or assigned sex females, have been less obvious to society, I think, historically. So here's a little fun fact.
Yeah.
So we think now historically that there were maybe 5,000 women who served as soldiers in the Civil War.
Really?
1860s in the United States, and they were for the most part stealth. They did not enroll as women because women didn't serve in
so they just pretended to be women.
They were presenting as males and taken as such, and and they served along with I would say other men.
Yeah, so they were passing, right?
They were passing,
even though they were women.
Yeah,
before they had any testosterone.
No hormones.
Yeah,
Exactly. Yeah. And so it's interesting.
Yeah. Yeah, it is.
And we were chronicling my career. I think we got to the right place, which is the questions coming up about, well, who comes to gender clinics and what do we know about transgender people? What do they need? What help do they need from us?
Yeah.
And some don't need any, maybe, but some are very troubled by their distress about gender, and some have other issues, and so we need to be prepared to respond to all of what they might need, whether they're young people or adults. And of course, someone can come to a realization of their identity at any age. I have, in my private practice, I have had adult patients who've transitioned as adults, both trans women and trans men. And I tend to see in my private practice more trans women, partly because they seek me out, because they learn about my history and they feel like I might be uniquely suited to help them. And many of them, as we work together, I think do feel more comfortable or confident that it's a good match, that I've done what they're trying to do. And so there's a certain comfort that they take in that, like, oh, she actually knows what this is about. And that wouldn't necessarily be the case with just any psychologist who is concerned about trans people.
No, of course not. But on the other hand, that could also be troublesome sometimes because your experience of being trans and transitioning can be quite different from other people's anyway.
Correct. But then let's remember that I was trained as
Yeah,
a
of
clinical
course.
psychologist
Before,
to be
yeah.
objective
Yeah.
and to not presume. And and there's such a thing as transference and countertransference. And so I've sought to be very rigorous about this. So when people come to see me, sometimes they worry I might be biased in one way or another. Some worry that I might be biased in favor of transition, and some people think that because I transitioned later, I would be less supportive of a younger person who wanted to transition. And so I'm very deliberate about telling people that it doesn't matter to me if you're trans or not. I'm going to help you the best way I can. And what we need to determine is who are you and what do you need?
Yeah.
And then we go from there. And I think I would say if you had a chance to talk to some of my patients, that they'd say, yeah, she didn't seem biased. I sometimes joke with, it's not kind of a joke, but with parents of kids who are gender questioning, and there might be some still open questions about, well, is this going to endure? Is this going to persist? That's a big topic today. And I say, I'm not recruiting anybody to be trans. I'm not looking to encourage people to be trans. I'm not looking to discourage people from being trans. That's not how I operate. And
do you think some in America do?
To be honest, yes. I mean, on both ways. That there are, as you probably know, as a psychologist yourself, there is such a thing as conversion therapy, and it's been criticized and actually made illegal in the United States for the most part, and I've decried it. A number of the people who worked in that area are friends of mine. One in particular is a gay man who has treated many gay men who have been subjected to conversion therapy.
Oh, really?
And
That's
so
horrible.
I've learned a lot from him. Yeah, and so those are people who are biased, I would say, and those who attempt to practice that and are attempting to dissuade people from the journey of being a transgender person or transitioning or whatever. So there's that problem. But on the other side, I think there are some people who are, in their enthusiasm for accepting trans identities, are not rigorous, and they don't do the proper evaluation of what does this individual person need right now. Because I, for many years, said, when you've seen one transgender person, you've seen one.
Exactly.
Transgender person. So the hallmark, I would say, of psychology itself, I sometimes use a French phrase, the raison d'etre, the reason for being of psychology is individual differences. And being a very well-trained clinical psychologist, I'm very attuned to individual differences. So someone might have an identity which has labels in different groups, but that isn't a full explanation of who they are, of course. So we have to more completely understand, what is this person's history? What has their experience been? What are their strengths and maybe some challenges, and take them where they are.
Yeah. And I'm thinking, because I've been a bit worried about the change in gender questioning girls like in their teens, because you haven't seen that before. What do you think
is happening?
Yeah, because that's happening all over in Europe, in all of the Western world, obviously.
It is.
So Because then I'm wondering if there is another explanation for that
Yes.
population.
Yes. Well, we have a unique point in time about these issues, and we have a unique cohort of adolescents and young adults that we haven't seen before. And there's a combination of factors that have come together at this point in time. I think in the modern era, I would say in the last, 70 or 80 years, teenage girls have it harder than teenage boys. And I think puberty is harder for natal females than natal males. The changes, physical changes, are more dramatic and more obvious, menstruation, breast development and so forth. And I think for many girls, this comes as, although expected in many ways, is still a surprise and hard to deal with. And I think that more so for girls than boys. And with more visibility of trans people and more conversation and proliferation of conversation in every venue of society about identity, that in previous cohorts of young people, they didn't think about their gender. Like the conventional thinking in the psychology of sex differences was that you were born male or female, and you grew up and you went through puberty, male or female puberty, and you developed into a young man or young woman. And maybe at some point you figured out you were gay. So you came out as gay. But nobody thought, oh, well, maybe I'll have a different gender development than biology dictates. So that was, and the literature on sex differences was very binary, male and female. I had a lot of the books. There was a paper published in the American Psychologist in 2016, which was a meta-analysis of all the literature, research literature on sex differences, and it revealed that that the much touted differences between the sexes, binary differences, was not as great as people expected. So that, and I'm going to be a little technical here, but because I'm a professor, right? So everybody knows about the bell-shaped curve, right? Yeah. The bell-shaped curve. And for those who've studied a little bit statistics or whatever, we know that the middle of the bell-shaped curve is the mean, or the average. And then there's standard deviations. And if you take 1 plus 1 and minus 1 standard deviation, that's 2/3 of a population. And the nature of the curve varies according to which trait it is and so forth, and how skewed it might be, how variant trait might be. So this meta-analysis was able to determine that based on many hundreds of studies of published research on boys and girls, males and females, that there were only about 4 or 5 traits where in the hundreds of thousands of subjects there were any statistically significant differences between boys and girls. Only a few. Okay.
Yeah, so the differences in each group is much what you call it, like larger than in between the groups.
Very good. You got my point. You would be an A student in my class.
Yeah, I was.
The within gender sex differences are vastly different than the across gender sex differences. So I'll illustrate by the numbers for a moment. It's a little technical, but you'll understand. The magnitude of the difference. Okay, so a standard deviation is 33% of the population. Okay, 33%. So so the magnitude of these 4 or 5 factors, traits, was on average 0.1 of a standard deviation, 1/10 of a standard deviation. So 1/10 of 33, which is 3%. So in a very narrow slice, these only a few factors showed statistically significant differences between boys and girls, males and females. But that's within the 100%.
Yeah.
So the variation within boys is, swamps the difference between girls, and same, the reverse is also. So that was, to me, clear evidence that even if you take a binary understanding of sex differences or gender differences, we're more alike than not. Okay.
Exactly, and there's a lot of different ways of being a girl and being a boy, and being a female and being a male. Like, so why do we have to medically change the body?
That is a big question, important question, and I guess one would objectively have to say we don't have to. So then, why do some, including me, want to change? And that is a very personal question, and the answer is even more personal, and that is we feel, those of us who are trans, who desire to transition, socially transition, medically transition, feel this compelling desire to be our authentic self and to bring our life in society and our bodies into line with our gender, our felt gender. And that the desire to do so usually arises from something we call now gender dysphoria, which is distress about the mismatch between how we feel we are in our gender and how we are observed by other people, or historically we have been. So in the DSM-5, as you know, the definition of gender dysphoria, I usually often say distress, because dysphoria is not something.
What is that? Most people don't.
It's not a word that people use in common communication. So I say gender distress. The number one, the first symptom is a marked incongruence between one's felt gender and one's sex assigned at birth. Okay, so when I'm teaching, I'll draw this out often, and sometimes with patients I'll say, so let's define what is a marked incongruence.
Yeah. How do you know that?
Yeah. How do you define that? And of course, two people might define it very differently. And this also leads us to the current sort of evolution of our understanding of trans identities, in that the International Classification of Diseases, as you probably know, in its 11th edition, I think Norway is in process of switching from 10 to 11.
Yes.
It takes a long time because all the computer systems and data collection and billing and everything has to convert. So, but in ICD-11, the current version, we say gender dysphoria is not in there. Gender incongruence is the closest that it gets. And between ICD-10 and ICD-11, which is published by the World Health Organization.
Yeah, so that's our diagnosis manual.
A diagnostic manual. Exactly. For all of healthcare.
Yeah.
So that transition not only changed the description, but also took it out of psychiatry and put it in sexual health.
Yeah.
And the basis for that was the belief that a transgender identity in and of itself is not pathological. It's not a pathology. It's not a psychiatric illness. It's a bit of a kind of a word game, in that we still use many parts of the world DSM. We still talk about gender dysphoria, but I think there's a strong push to move to depathologize trans identities. So I think about this all the time because, of course, I don't think I have a psychiatric illness just because I'm transgender. Okay, and I think many trans people would say the same. You know, I'm trans. It's not a psychiatric condition. However, using a psychiatric diagnosis is necessary in some countries for the health system to take on a patient and provide care and pay for the care.
Yeah, because you need a diagnosis to be a patient, and
Yeah.
because you actually need a form of therapy, like both psychological, also because it is distressful. It
Yeah.
is not easy to come out as a trans person most of the time.
Most
usually,
of the time, exactly.
Yeah, and also you need treatment, like
Yes.
medical treatment.
Yeah.
Well, not everyone does, but
Yeah.
most of you prefer to change things biologically so that you
Yeah.
look more like a woman. Have you taken? Can I
Hormones,
ask you?
yes.
Yeah,
Oh, yes.
hormones.
Yeah.
and all.
And
Have you?
have had surgeries, yes.
Yeah,
Yes. Yes, exactly. So, and that felt right for me. And historically, that was typical of trans people, trans women, particularly. So yeah, and I think many trans people would say, I want access to hormones and surgery, whether I do it now or not. But I want to be able to do that, and it is very meaningful. You know, I would say not only personally, but by extension, a lot of the trans people I have worked with over the years. So when young people are presenting and we do the evaluation and we determine who they are and what they need, you know, many of them do want to have medical transition, not only social transition, but medical transition. And in the clinic I worked in, as with many clinics around the world, the evaluation of the patient is necessary to proceed to get puberty blockers, to name one class of medications, or cross-sex hormones, as we usually say, and certainly surgeries. You know, the most surgeons in Europe and the United States require that a psychologist or a psychiatrist would evaluate a patient, ideally work with them for a period of time. I mean, that used to be the standard, was, you know, you had to work with a psychologist for a year or two before they would write a letter of support or recommendation for surgeries. And we don't insist on that any longer for adults, but we are still talking about what do we require for children who might want to have a medical transition of one kind or another.
Yeah, because in Norway, we give puberty blockers, so that stops the development that you usually have throughout puberty.
Mm-hmm.
And when you're 16, you can start cross-sex hormones if both parents and, of course, a psychologist or psychiatrist or a team actually of professional healthcare workers in the field say that that's something they're allowed to do, or that's recommended.
Exactly.
But earlier it wasn't that strict as it is now, because it was more some in the primary health care that took that job. And so it's been really restricted the last couple of years. But I'm still a bit worried because so much happens during puberty. So because even if it's an adult, like you are fully developed mentally, like you have gone through the puberty, and everyone is distressed in puberty when it comes to identity and stuff like that. So if it's not even presented before the puberty, then I'm really concerned, because everything will probably just resolve itself throughout puberty, because you have sexual development, you have identity development, and you have gender development. You have everything throughout puberty. And also, I'm wondering how many of the kids that are identify themselves as the opposite gender, how many of them would resolve that throughout puberty?
Yes.
Because in the studies, you don't have any control groups, so you actually don't know what would have happened to those kids.
That's right. Well, as we were talking earlier, not only did you were a participant in the conference that was, it seems like longer ago, but it was yesterday.
Yeah.
It was yesterday. Where we talked about these issues. And there has been renewed controversy over the issues you just raised, where we want to know who are the children for whom, if any, puberty blockers are appropriate. And then what do we know about what puberty blockers do? Okay?
Exactly.
And then at what point do we make decisions, if we do, about adding cross-sex hormones? Because we can't use puberty blockers indefinitely medically. It's unwise because it pauses puberty, as implied by the.
Yeah, it stops all types of hormones.
Well,
or what does it do?
It stops It stops the sex hormones.
Yeah.
So
both male and female sex hormones, because we have both genders.
Well,
right?
Yes, on puberty blockers, yes. But we don't have a lot of long-term research on the use of puberty blockers. And we don't know, as you say, we don't know, does the pause affect not just the advance of physical development, but does it pause cognitive development? And this is one of
emotional development.
And emotional development, exactly. And we're concerned about it. I mean, many of us are very concerned about it. I've been saying for a few years, I'm urging caution in the application of medicines for young people for some of the reasons you imply. Today, not yesterday with the main conference, but today with colleagues who were in the leadership group and speakers from yesterday, we were talking about what research do we need to satisfy ourselves that we know what's going to happen, which young people are going to benefit from these medical interventions, and then what are the consequences? Your question about, well, could this have an impact on cognitive development? And many are concerned that it could. So, we by protocol, the endocrinologists or physicians who prescribe puberty blockers won't do it for more than 2 to 4 years. And there have been some sort of obvious, very publicized cases of problems with that, where there are issues with bone health, bone mineralization, which is suppressed to the same level of growth as childhood, whereas the sex steroids, testosterone and estrogen, speed up bone mineralization so that we can have healthy, strong bones for the rest of our lives.
Yeah.
And nobody wants to have weak bones, particularly not young. So there's that issue, and then the cognitive. So we were talking actively about, how can we establish some research protocols to properly evaluate this and satisfy ourselves that we know what is going on and that we can use that to make decisions. So in the United Kingdom, as you know, there was a big study and the report released earlier this year, the Cass Commission, and you've met Hilary Cass, Dr. Hilary Cass, and in that report, they did a number of very technical evaluations of research, which the term we use is systematic evidence reviews. And these are the reviews that are done in preparation for clinical guidelines. And such reviews have only recently been done. They were done in Finland about 4 years ago, and a couple of years ago they were done in Sweden, and now in the last year and two they were done through the Cass Commission. And these reviews confirmed what many of us have been thinking, is we don't have a perfect evidence base for these medical interventions. We have some evidence, but we're not satisfied that it's great. In fact, it's been rated in these reviews as weak or very weak. So this creates a motivation for us to do the research that I was just talking about. And so I'm hoping I can participate with colleagues in the United Kingdom who are going to now do some research on puberty blockers, and pretty sophisticated research. As you may also know, the gender clinic at Tavistock in the United Kingdom was closed down a year and a half ago or so because there was an outcry about whether we had sufficient evidence for the use of these medicines, and concern that maybe we did not. So the Cass review was in part, Cass Commission and its review was in part in response to these concerns, which are legitimate. And I think there is widespread agreement that all of us, whatever our role, whether we're trans or parents of gender variant young people or clinicians or scientists, we need to have better answers to these open questions, and that's how we must proceed, because we are all committed, all of these groups are committed to the safeguarding of children. And there are, and I would say, I have a long career where I've been concerned about the safety and the health of individual children and in their families and so on. And so these are questions that need answers. We're going to try to get them. It's going to take a little while because there's more research that needs to be done, and we'll be better able to respond to the needs of young people in the future. Gender variant kids who are questioning their gender are not going to stop questioning their gender in the meantime. So we still have to. We can't just say, well, come back in 2 years.
Yeah.
We'll respond to that. So I think in Norway, as in many other countries, the health authorities, have sort of recognized these challenges and pivoted to a more cautious approach. The stereotype in the United States of those who are opposed to gender youth care is that such care has been banned in Europe.
Yeah.
And that's not true. But it has been we've pivoted in Europe to a more limited approach under protocols, and in some cases research protocols. So in the meetings the last few days, my colleagues from Sweden, Norway, Denmark, the Netherlands, United Kingdom, we're all here, people I know and have great respect for, and they've been involved in these systematic evidence reviews, and many of them are the very researchers and clinicians who've helped this population for many years. They're the experts in the world, really. So if anybody's going to be able to do it,
it's them.
It's this group.
Yeah. And I'm really glad that they are taking this seriously and researching, because I've been really worried, because when almost all of the kids who starts with puberty blockers go on to cross-sex hormones and surgical, what do you call it, surgeries, of course. Yeah. So that's what concerns me, because if you start this path, you will continue, and I am a bit afraid that some of those kids might be only lesbian or like gay.
Yes.
Because now we learn in school that what you like to wear, what hairstyle you have, and what you like to do determines what type of gender identity you have. So I'm concerned that the society also makes children more gender questioning that they might have been if they didn't watch it on social media all the time on these apps. And so I'm concerned that might be some of the reasons why more children feel like the opposite gender, and when they haven't gone through puberty they don't even know they're gay. Right? So I'm really concerned that we are medically harming bodies that are healthy to begin with, because it's not that there's no complication with changing your gender, and there might be gay kids that we ruin in a way. Like I'm using strong words here because I'm really concerned as a psychologist, because I know that a child aren't mentally mature enough to take such big decisions.
Yes. Well, of course, in Europe and USA, Canada, parental permission is required to get these medicines. But that aside, yes, I share your concern. I have for some years been talking about the overreach on the part of some clinicians who presume that, and they say so, they presume that every kid who says they're trans is trans. They don't need an evaluation, it's self-determination. And, the population is very complicated, and many have co-occurring or pre-existing other mental health issues. And, I think it's premature, if not inappropriate or even reckless, to just take a child's word for themselves. The adult trans community thinks it's a great thing, just trust kids, take them, because maybe in their case, they tried to tell people about themselves and were not believed. Okay. Yeah. So there is this historic problem and, cumulative trauma in the adult trans world, but they're not being objective about the fact that the cohort of teenagers has changed. And in most of these societies that we're talking about, the climate has become more accepting of trans identities and less stigmatizing than it was. So there's a complicated mixture of factors. But I've been speaking out about this. Some of the research 20 years ago about young people who were asserting trans identity showed us that in that time, again, a different cohort, but in that time, some kids who were expressing a gender variance turned out to be gay.
Yeah.
And so we had words in the literature of the time of proto-gay, and as you said, you're a psychologist, most people don't really know they're gay until after puberty, till their sex drive kicks in, and then they have attractions and they have certain reactions to other people, and they might have experiences with partner intimacy and so on. And so for kids to assert a gender identity absent any partner sex experience and a recognition of what is their sexual orientation or attractions is unfortunate. We've done a good job of making sure people understand that gender identity itself and sexual orientation are not the same thing. But I say often, it's not that they're completely unrelated, and the way they're related in the individual person is experience. That, when we go through puberty, our sort of sexuality is awakened, our libido rises up and we feel sexual and wonderful, that, this is a part of being a human being, is to be sexual and enjoy sex and have sexual pleasure. One of the subtleties which I talk about sometimes, and it surprises people a little bit, is some of the very young people who are asserting a gender variance, not only they're young, but and they might be very insistent about their gender identity, but they've had no sexual experience, certainly no partner sexual experience.
Well, they can have if they've been sexually abused, though.
Well, yes, if they've been subjected to trauma, yeah. But for the majority of such kids, they have not been victims of sexual abuse, and so when I'm evaluating a young person, I end up talking with them about their sexuality, not to be intrusive, but to be comprehensive and also holistic. So. Often people are surprised when I say I talk to some gender variant young people who not only have never had a sexual experience with another human being, they've never had an orgasm. They don't masturbate, which, the vast majority of humans masturbate at some point. And so they've not had the experience that serves to illuminate our identity in terms of sexuality and sexual attractions. So, we're in the dark a little bit about, well, what do we know about this young person? What can we predict?
Yeah, and also, how does the puberty blockers affect your sexuality? Because it develops throughout puberty.
Yes.
So if you change gender with surgeries when you're an adult, when you have a penis, you can make that vrenge is what you say in Norwegian, but yeah, but you have it's developed enough so that you have when you are a kid, you have a kid penis, a boy penis, and
right.
you are making that to a girl vagina, then you don't actually have enough skin and not
right.
have, maybe you can't get an orgasm.
Right. Well, there's the two issues which are related, as you say, are that if you don't, as a natal male, if you don't go through puberty, your genitals don't grow.
Yeah.
And so for the common surgery to create a vagina, a neovagina and vulva, the penile inversion technique requires the use of that material. And what happens, and this is a little graphic, but we're not on television with, right?
No. People decide themselves what to watch.
Okay, right. So the important thing, some people have this notion that the penis is cut off,
mm-hmm.
but that's not what happens. What happens is the skin around the penis is taken, and that's used later for the vulva and the lining of the vagina, the neovagina. But the neurovascular bundle inside the penis, the core of the penis with the nerves and the blood, are repositioned essentially to be the clitoris. Okay. And that's the most sensitive organ for males and females.
Yeah.
So, what I say is if a natal male who is asserting a female gender identity has never masturbated, most of them have never had partner sex. If they've never masturbated, they've never had an orgasm. They don't know what it's like.
No.
And the surgeons I know who do the surgery say that they actually want kids to wait a little longer to go on puberty blockers or cross-sex hormones because they want kids to masturbate and feel sexual pleasure, because that is going to be, predictive of their ability after the surgery to feel sexual pleasure and have an orgasm. And so we have a generation of young people who they're conflicted. The natal males, trans girls, are conflicted about their penis anyways. They would rather not have a penis, but in some cases they don't touch it because it's abhorrent to them, but they don't realize that it's a gift to feel sexual pleasure, and that they need to. This is a little funny way to say it, but they need to exercise their penis so they can have sexual pleasure later as an older person.
Yeah. Yeah, because we take away their sexual pleasure as well when you give them puberty blockers too early. And
I'm going to have some more of your delicious coffee.
Yeah, maybe it's a bit cold now. We can take a
Well,
small break if you like.
That's okay.
Yeah.
Maybe.
Yeah, we
Maybe
can take a break.
Short break.
Yeah. My podcast, Snakk med Silje, in English Talk with Silje, deals with many different topics where my guests bring interesting perspectives that I want to understand better. I invite people I both agree and disagree with. The aim of my podcast is to make room for longer conversations that help us expand our horizons, understand each other better, bring people closer to each other, and reduce stigma, and thereby contribute to us becoming a little less judgmental. On my YouTube channel, I have created a playlist with my international guests for those of you who don't understand Norwegian. I greatly appreciate anyone who wants to support the podcast by following my channels, sharing my content, or donating any amount through Wise, Vipps, or other methods explained in the description of this episode. Thank you.
I learned to drink black coffee, drinking the coffee my father made. And specifically, it's a little funny to say, but so one of my first jobs was as a paper boy.
Okay.
Delivering papers in the morning. And I grew up in Minnesota, which, like Norway, has very cold winters. So the first thing I would do would be to have a hot cup of coffee, which was very good to wake me up and warm me up and prepare me for the cold to go out. So I'm used to drinking coffee, first thing, hot and strong coffee, and black. My father always had black coffee. I've come to acquire a taste, like many people, for coffee with cream and sugar, but I'll only drink that if I'm out at a restaurant.
Yeah.
Fine dining. I would have an evening coffee after with dessert. But otherwise I drink it black, and I don't usually drink it after early afternoon.
No, I think a lot of Norwegians drink it black. It might be one of your part of your Norwegian inheritance.
Yeah, exactly.
But yeah, we talked about gender affirming care for kids and young people. And Dr. Cass have written
a big report.
Yeah, and there's a lot of misconceptions about that report.
Yes, there are.
There are some trans activists who are really, for some reason, are really angry at Hillary Cass, and also tells me things about this report that I don't think is true. I've heard people say that there was no involvement from the transgender community and things like that, and that's not true.
It's not true. And if one reads the entire report, which I encourage everyone who's interested to do, you realize that she took great pains to be sensitive to the needs and perspective of everyone involved, including trans people themselves, trans youth, their families, clinicians, of course. And so for the last few years before the report was written, she had essentially a group of I don't know, advisors maybe isn't the word, people that she talked to who were clinicians and scientists, doctors, and also patients and their families, including young people. So she was routinely reporting to them what's going on and getting feedback. And as is discussed in the report, she, in addition, her team did many focus groups with conversations with people, all types, older trans people, younger trans people, their families and many of us who have worked in the area, and so she was listening to trans voices, including mine, because I talked to her a number of times, and as some of the accusations made about the report are simply unfounded. Another one that is common is that she eliminated research that would have supported care for trans people. And that is not true either. The systematic evidence reviews require a very rigorous protocol for which studies to look at and how to determine whether they were to be included in the final review or not. And they initially reviewed everything and then determined which were the ones that they were going to use in the final determination of what evidence exists to support care for trans people. And these reviews have been corroborated by the experts in Sweden, and prior to that, Finland, and the reviews were done by people external to the CAS Commission. They were done by scientists at York University, and some similar reviews have been done by people at McMaster University in Canada. Both institutions are known as advisors on the development of clinical guidelines and the systematic evidence reviews that underpin those clinical guidelines. So the criticism that she deliberately excluded research is just completely untrue. She did not. And as I said earlier, she's taken great pains to try to pay attention to the voices of all the people that she should.
Yeah. Yeah.
And she says so in the report. If you read the report,
exactly,
she says, "Here's what I did."
Yeah.
And then, in addition to what we've just talked about, she had a team that evaluated the clinical guidelines from 15 different sources, including all the ones that people who are expert in the field know about, the WPATH and the Endocrine Society and others, and any guidelines that have been published in Europe and a few other countries for that matter were reviewed, and and they subjected them to some rigorous evaluation and concluded, and I agree with the conclusion, that only the guidelines based on the systematic reviews in Finland and Sweden meet the most rigorous test for what to do. And this does not mean, by the way, that Dr. Cass ignored everything else or didn't consider it in the report. She did. She just followed the results of these systematic reviews, and that's the conclusion was, we don't have the best evidence support, empirical support for the use of medicines with young people. We have some support. We certainly have reports that are consensus driven by people who've worked in the field. And it's not, and the recognition of that is not an attempt to deny care to trans people so much as be objective about it. And as we were saying earlier this evening, we have, a number of us have gone on to say, okay, now there are some gaps in our knowledge, and therefore we need to close those gaps. We need to answer some big questions, because all of us, as we were saying earlier, all of us are concerned about what's best for children who are gender questioning.
Yeah. Yeah, and yesterday at the conference, it was some
demonstrators.
Yeah.
Yeah. So I'm not known in Norway.
No.
So
no one.
I blend in.
Yeah.
A tall Norwegian woman. So I left the conference hall out the front door where the demonstrations were occurring, and had lots of questions in my own mind about it. But Dr. Cass, because she's been a target of not only criticism, but threats,
Yeah.
was escorted from a different entrance or exit. And so to make sure she was safe. And it's really unfortunate that some misunderstand the work of Dr. Cass, and for that matter, my work. I mean, I get such criticisms in the United States because I call for caution. I am trying to be truthful about what we know and what we don't know. And some people they expect me, being who I am, to be a full-throated advocate for all things trans.
Yeah.
24/7, 365. Yay, trans. And I'm sorry, I'm a scientist. I'm a clinical psychologist. And I'm not a cheerleader, and
No,
this is...
you're not an activist. You're
No.
you're trans yourself, and you are a clinical psychologist.
Yeah, I'm an advocate.
Yeah.
I'm an advocate. I've been a very clear, arguably compelling advocate, but I've been also tried to be reasonable and do what I thought was the right thing. And I'll go a little further to say, and you were at the meeting where I was somewhat sarcastic and playful
Yeah.
about what's going on in the United States, which is kind of crazy. And there are lots of excesses, and I have, as well as a few of my colleagues who are like-minded with me, have called out some of the craziness and said, you folks have gone too far. To use maybe a Norwegian metaphor, you're out in front of your skis. You shouldn't be down the hill in front of your skis.
No, you shouldn't. You can't go too far ahead.
No, you will not be able to keep going if you lean too far over your skis.
Yeah.
So this has been a challenge, and yet I've been a full-throated advocate for trans interests. Trans people should get what they need. Absolutely. I've worked in some areas that are very controversial, including as an advisor to prison systems in the United States, where trans people have been not treated well historically. And of course, prisons are very conservative institutions, which are binary. There's male prisons and female prisons.
Which makes sense because of the safety.
Yeah, it makes sense. But trans people don't fit.
No.
In some cases, particularly the trans people who have wanted to socially transition and medically transition and so forth. So I've been advising people in these systems how we can do this humanely and safely.
Yeah.
And that's, again...
But it's really
hard. It's really hard.
Yeah.
So just as I am concerned about the safeguarding of children, I'm concerned about the safeguarding of people in prisons. Not just trans people, but everybody who's in prisons, including not just the people who are incarcerated, but the staff. Because there's a lot of, as you know, and unfortunately, the United States has a lot of people in prison, jails. It's a dangerous place.
Yeah.
It's a very dangerous place.
And the polarization in America is really large. Like here in Norway, it's starting to be more polarized, but not the same way.
26 states in America have decided in the state legislatures that they're not going to permit gender-affirming care for minors,
but for adults it's okay.
And there's some concern that some legislatures may want to also prohibit medical care for trans adults, which, please. That's way too far. So,
but don't they give any care for the children? Like
No.
if they prohibit, for example, the medical treatment of children, that would be more okay if you can actually meet the families and talk to the children and give them health care.
No gender affirming care,
socially.
no psychological treatment for a gender questioning, gender variant child is permitted. And in some of the states, they criminalize it. So for the medical doctors who historically have maybe offered cross-sex hormones or even puberty blockers, if you do that in those states, you can be prosecuted by the state and sent to prison.
Yeah.
It's in some states it's a crime. So
yeah, I find it really, really disturbing that like both ways, like all or nothing.
Yeah.
Shouldn't it be up to the healthcare system and not the political parties to decide?
yeah.
Because I don't think in Norway, well, you can ban things, but it's strange that you can do it so harsh. I don't know. There's it's a bit strange.
That's my perspective. I make that case. With a colleague and I, we wrote a report. It's called an amicus brief to the Supreme Court of the United States, the highest court, which has taken up consideration of whether such bans are legal, permitted. And it's one state that was passed such a law, was sued by others, and that the appeals court, the next court, said the state can implement the law, the prohibition, and the people suing the state sued that, and that now that's gone to the Supreme Court. And I wrote a document to say we are opposed to outright bans, that we think that the decision should be with families and medical providers, and that the legislature shouldn't prohibit care that doctors and the families they serve feel are indicated. So I've taken a very strong position about it. I think it's a very bad sign. I'm opposed to bans on abortion. I'm opposed to bans on gender affirming care. I don't think the legislature, which in the United States, I don't know about in other countries, but the legislators in the United States at the state level are very rarely healthcare professionals.
Yeah.
They're usually lawyers by profession. And they're ill-equipped, I think, to make such a decision. And I think it's kind of morally wrong for them to decide for everybody.
Yeah. But I can also understand, though, because I don't like it if it's conservative Christians who try to ban or to, because of moral reasons, does something to the healthcare system. But I also find it troublesome if people are ideological, really, what you call it, if they have like a gender ideology about that all children tells the truth all the time when it comes to exactly that.
Right.
Because the WPATH-files have shown that some of the people are trans activists at the same time as they are healthcare professionals. And it seems sometimes that the ideology and the political side of it goes before the safety of these children.
Yes.
So that it seems like a lot of people in America have lost that that the WPATH, for example, WPATH and US PATH have lost some credibility because of those.
They have. I agree. And the disclosures that have been coming forward about the internal communications and the fact that there was influence brought to bear by outside forces on the standards of care, the SOC-8 that were published in 22, reveal a pattern of susceptibility to political influence that is unwise and unfortunate. You did some research on me, but you may not know that not only was I the president of US PATH and on the board of WPATH, but I resigned. I resigned out of disgust because I was bringing up some of my concerns about such things, and I said we need to be transparent. We need to follow our best guidance, and we need to talk to the public through the media about what we know and what we don't know.
Yeah.
And I was kind of overruled, and I shared a quote in the meeting yesterday, about revealing just how calculating the approach was from WPATH since I left, about tailoring what they say rather than speaking truthfully about what's true and what's not true. And I'm appalled. I'm very disturbed, very disturbed. And I have made a point to communicate. Part of it is, doing the podcast with you is I want the public to know what we know and what we don't know.
Yeah.
Our reservations, our caution. And there was a feeling among some of my colleagues that the public didn't have a right to know. That we have no obligation to talk to journalists. We have no obligation to publish what we know. We can publish only what we want to publish. And that misjudgment, in my opinion, is revealed now for what it is. The WPATH had contracted with Johns Hopkins University, an important university in the United States, to do systematic evidence reviews.
Okay.
And did not use them
Really?
In the development of the SOC-8, and actually directed Johns Hopkins, that they'd contracted with, to not publish. So, that's just folly.
Yeah,
it's
that's
just
unheard of.
It's unscientific.
Yeah,
it's very political.
Exactly, and that's what troubles me when political ideology are more important than the safety of patients.
Yes, very bad. It's very bad. And I say it in a softer way sometimes in the United States, but I think WPATH has lost its way. It's lost its moral core, and it's lost its standing as the authoritative organization, because it's now demonstrated that it's not operating purely on the basis of science.
No, it seems like it's hijacked by trans activists.
It does, and I agree. It certainly seems that way, and I've been worried that it was. So I did some interviews back when I was in leadership, and I spoke, as I often do, truthfully, in a forthright way, and some were very critical, even though in private meetings they would say Erica was right about what she said. I agree with her in private.
Yeah.
And so I thought, well, my voice will be heard if I'm outside the organization, which is true. And, I have many journalists who now do trust what I say, because I'm measured. I don't claim to know things I don't know, and so forth. And you listened to me yesterday. I keep thinking it's a few
but
days ago.
this is probably gonna be in a couple of weeks on YouTube and Spotify and stuff like that. So yeah, but we also yesterday at the conference we also saw that everybody agreed that there's a lot of comorbidity when it comes to these gender identity problems and other psychiatric diagnoses. Not other anymore, but so, and some people might think that you shouldn't have the gender affirming care the same place at the psychiatric hospitals for kids. I'm not sure what you call it in Norway we call it
Sykehus.
And we call it not psychiatric, but we call it psychological health places.
Well, most gender clinics in the United States are not co-housed with psychiatric facilities. It's separate.
Yeah, but
so,
do you think it should be like it is here in Europe?
Yes. No, I think it should be separate. And certainly there are young people who and people of all ages who have psychiatric conditions that require treatment.
Yeah.
Deserving of treatment. One of the things I said yesterday was there are some who believe that the psychiatric problems or symptoms are a consequence of the trans experience or the distress from gender incongruence. There's no evidence of that. There's also no evidence that just providing medical transition and help for gender will cure the other psychiatric problems. So the way I said it, I think, is the perspective by some is you either treat concurrently with the gender distress the other psychiatric issues, or you assume that those conditions will be solved by the gender, and there's no evidence of that.
No.
I mean, it's preposterous. We don't cure depression, we don't cure anxiety disorder, we don't cure trauma or autism or anything else by a gender transition. And so the long history and dialogue in psychiatry of coexisting or pre-existing conditions is that there needs to be a decision about, do you concurrently treat or consecutively treat, and that presumes priority. So the example with young people is, if a young person is actively suicidal, do you assume that if you give them the hormones, they will stop being suicidal? That's a dangerous assumption.
Yeah.
And there must be a priority on the safety of the child. So let's make sure that they're not emotionally unstable, and that those issues are addressed, not to prevent gender care, but to prioritize. And
and that's why I think it should be together at the same place: the mental health care and the gender health care.
Except not all gender questioning kids need psychiatric care.
No, but it could be the same place because so many of them need both.
Well,
shouldn't it be in the same area?
Many do, but as I'm trying to say, I think if you approach it objectively, you can sort out what needs to happen with an individual child at that time, and we're still in the throes of trying to understand this current cohort of young people, which is more complicated than previous cohorts. Yeah. I'm a psychologist this long, so I've dealt with arguably 3 generations of cohorts of teenagers. This is by far the most complicated in the United States, at least. The incidence of mental health problems is higher than it's ever been documented in this cohort, and we're coming off of all the problems associated with social isolation in COVID, and the unprecedented consumption of social media, which has had an impact. We haven't really understood it very carefully, but in my own opinion, I think there are a lot of young people who have been adversely impacted by social media. And there have been congressional hearings in the United States about this, and criticism of some of the social media companies that their algorithms are designed to further additional consumption by young people, that they're essentially addictive.
Yeah.
Okay. And so, you have a lot of bad stuff on the internet. You have so-called social influencers who, without qualifications, are acting as though they're the psychologist for the strangers who are watching their, content, and they're saying, do this, don't do that.
Yeah.
Trust me, don't trust your parents.
Yeah. And
crazy stuff like that.
Yeah. Yeah, and that they actually learn from those influencers what they should say when they come to the gender clinic so that they can get hormones.
Right.
And told that, if your parents say this and that and this, they are probably transphobic and you should just get away from them.
Yeah, in the USA, we say that's coaching, maybe grooming is the word we use, which is, and the concern on the part of some people is that some of these so-called influencers are really closeted pedophiles, and that they're trying to take advantage of young people. Maybe in the extreme examples, but their influence is not helpful. And some young people who've consumed a lot of this content do come prepped to say what they think they have to say to get the hormones. So, some young people will actually, I'm going to say, in my opinion, fabricate their history. So they say, you ask them, well, when did you first start thinking that your gender was different than that aligned with your sex at birth? And they'll claim that it was when they were a young child. These are teenagers now. And the parents are shaking their heads saying, there was no indication, there was no reason to think that our child was gender questioning or gender variant. And then I've literally had situations where kids tell me stories that are made up to try to confirm their narrative about, because they've been coached, you have to be convincing that, you always felt this way. You were always born in the wrong body and you always knew this, it's like, no, you didn't.
No. But why do you think that young girls, that's the cohort that has been larger the last years?
Yes.
Why do you think they want to be trans?
Well, I think they want to be boys.
Yeah.
And they think they don't want to be girls.
Why
some of it is body dysmorphia.
Yeah.
Is like they're uncomfortable with their pubescent body. Some of it, as I've said many times, is I think the experience of girls who go through puberty in Western society is that there comes a point when your physical changes are such that you begin to look more adult as a female than as a girl, as a child. And this attracts, by instinct, the male gaze. So some girls find that men are paying attention to them, older males are paying attention to them in a way that they didn't when they were young.
Yeah.
And this is uncomfortable. But instead of preparing our girls for this, because there's nothing we can do about it, it's instinct for the males to look at females.
Yeah, we can do like the Islamic countries does. We can put on some more clothes. No. That's not a solution.
That was a joke.
Yeah, that was a joke.
Yeah, no, but I think we can better prepare girls to say, well, not only are you going to change, but how society treats you is going to change over time. And, you just need to get used to it. And many mothers have said to their girls, it will be uncomfortable for a while, but eventually you'll find that you kind of like it. Certainly presuming that many girls will be heterosexual.
Yeah.
And so, feeling attractive to males is a kind of a pleasure.
Yeah.
For most, I think.
Yeah.
Most of the time.
Yeah. And we know that the same age group, that there's a lot of different psychological issues that are also a bit contagious. For example, when it comes to self-harm and anorexia, and that's the same age and group. So do you think it might be another way of expressing pain in a way?
Well, it is, but I'm actually reading some of the research on development in neuropsychology. And one of the things that the neuropsychologists are now able to document is that the areas of the brain that are responsive to social cues mature first, instead of the higher cortical function of the ability to have foresight and planning and anticipate. And so kids the brains of teenagers are more reactive to social reinforcement for a period of time than they will be when they're balanced by the other parts of the brain that involve judgment and planning and all that. So I think there's a reason biologically why young teenagers adolescents are more susceptible to social influence. And, another one of the controversies in this field is, is gender identity contagious socially? And I've never said it is, but those of us who are quite knowledgeable about developmental psychology, we know that peer influence is very powerful, as I was saying, in terms of the brain and all that, in early adolescence. And it's not this area of gender development, or even sexual development for that matter, is not immune from such peer influence. So if we accept that adolescents are susceptible to peer influence, why would this area not be?
Exactly.
It would not be the exception. So then, what do we do about it? And of course, what's interesting is in healthy development, there's a period of time, this early adolescent period, when young people are more susceptible to peer influence, and that some of the influence, the healthy influence of adults who are older, including parents, it returns to being important as the young person gets older. One of the things I've said for a long time is it's interesting to talk to people who in the United States who are graduating high school and they're going to university, and they say things like, yeah, my parents are idiots. They don't know anything. And then they go to university, and then 4 years later they return home and they say things like, wow, I can't imagine how my parents learned to be such decent people in the time I was gone. Yeah, and it's like, but they finally realize, okay, they had a perspective about their parents. It was a little bit time warped and a little bit contextual in terms of, they were a teenager and all that, and they were paying more attention to peers and less to parents. When we're children, we pay a lot of attention to parents and some to peers, but then in adolescence, it flips a little bit. So I think this is yet another factor here that's at work, where in a society where we do segmentation of social experience by age groups, that young people spend their school day, and often more because after school activities, and then now we have technology connections. So maybe 10, 12 or more hours a day, young people are really paying attention to their peers, not to parents. They're trying to ignore their parents, shut them out, and be with their friends. So is it surprising that would have a bearing on what they think about everything?
No, it's not.
No, it's not.
They're just teenagers.
They're just teenagers, exactly.
Yeah, and they do things that they themselves know are harmful, but they do it anyway.
Mm-hmm. Yeah.
And they are really, and if you get positive attention from other people, that in itself can drive you to do a lot of things that might not be that good for you.
That's right.
And also thinking far ahead. You're not that good as seeing consequences.
Correct.
And then you can do a lot of.
Well, this is why we all know that young people are engaged in risky behavior to a greater extent for a period of time than they will, and that will moderate. It's why in the United States, these are a more financial example, why insurance companies charge more for auto insurance when there are young drivers. In the United States, most states you can get a driver's license to drive a car on your own when you're 16. And we know statistically that 16-year-old drivers get in more accidents. They make more mistakes. They're inexperienced drivers, so that's part of it. But they also take risks. And so by the time that the young person is 25 or older, that added susceptibility to risk-taking is moderated and goes, at least for most people, goes away.
Yeah. Yeah, and that's why it's important also to know that the brain develops normally, even though you take puberty blockers, for example.
Right. Thank you. That's a good connection back to something we were talking about. So if you delay, as you just said, the full development of the brain, you prolong this period of risk-taking, you prolong this period of susceptibility to peer influence, and so you essentially delay maturation.
Yeah, and I'm also worried that you might delay identity development.
It's possible. It's possible. And again, we have more questions than answers about this. But yes, I think we all know from psychology that identity development is a normal process or developmental milestone for teenagers. That's the famous Erik Anderson, psychologist, talked about identity as the developmental task of adolescence. And I think that stood the test of time as a recognition of how are adolescents different from younger children and how are adolescents different than adults. So we would say identity formation is an ordinary developmental process. Everybody does it. You can't become a full adult without going through your version of identity development. But as we've had this conversation, there are many factors in today's environment with this current cohort of adolescents that we didn't have in previous cohorts. And so we could say maybe it's more complicated than it used to be. If adolescents, in fact, if I could take one more tangent a little bit. So 150 years ago, people didn't talk about adolescence. There was no widespread recognition of this period of time between childhood and adulthood. You were a child, and usually at the point you hit puberty, you begin to take on adult tasks. And if you're in a typical family, not a wealthy family, but if you're in a typical family, your family business is a farm or a trade, and you go to work.
Yeah.
You go to work. So, we had child labor laws come into being in the late 19th century because all the children were working in farms and factories and so forth, and we came to be more modern and think, well, we should not expect 12 and 13-year-olds to do adult work.
No. But do you think that might also be that we are now more individualistic and more concerned about our who we are and our identity now than before? Because before you just had to work. You didn't have time to just stop and reflect, who am I? What should I do? Okay, you have to work here because that's where your dad works, and that's your only option.
That's right. Well, yes, it is true that with developing society and with affluence and with the development of technology and so forth, we have resources that we didn't have, in years ago. And so when young people look around, they have a chance, as you say, to experience and process their lives in a way that wasn't true for previous generations who, as you just said, you just go to work, you pull your weight in the family.
You're a boy because you have a penis.
Yeah.
And you're a girl because you have a vagina, and that's okay.
And as if you're a natal male, if you're a boy, as a result of puberty, you develop muscles and you get larger and stronger, and then you can help the males in your family in the family business or on the farm. Yeah. So we had,
it was easier in a way.
It was it was simpler. Yeah.
Simpler,
13 and 14-year-olds are driving the tractor, or harvesting the crops or taking care of the animals or whatever it is. So yes, it was a different life. And now we're in the modern era, and and we have protracted this period of transition from childhood to adulthood. In fact, a lot of people now talk about transitional age youth, which is generally 18 to 25, which is between high school and 25, and that in some respects, people in that age group in modern society are still in adolescence. Yeah. They're still processing their identity. They're still preparing for their life's work. They're not yet married mostly. In another era, people married when they were teenagers and started having children right away because there was no birth control. And on the farm, the more hands you had, the better. Yeah. Get the work done.
Yeah. Yeah, so it's different. And also, when you think about brain development, your brain isn't actually fully developed until you're 25. Mm-hmm. And that's the reason in Norway you're not allowed to have a sterilization before that, because you're not mature enough to take that choice. So that's also probably why many people think that, okay, but if you have gender identity issues, then you're allowed to
make an exception.
Very, very early.
Yeah.
So I can understand that thought in a way.
Yeah. Well, and that kind of theme permeates all the issues we're talking about, in that to what extent are trans people exceptional or should be treated as exceptional? And some of the criticism of gender affirming care is, well, we shouldn't treat these children different than other children. We shouldn't allow variation from the typical course of growing up. And so we've now moved into nuance upon nuance, I guess, in our conversation.
I know, yeah. But what do you think about people talking about the woke mind virus?
A virus?
Yeah.
Well, it's not a virus.
But some people use that term.
Well, I think some of the same let's see how to say this. So I think some of the same thinking that infuses, woke perspectives, infuses some segment of ideologically oriented people about gender. And there's some overlap. So in the United States, for example, we talk about structural racism and privilege and inequities in terms of history, and that these should be addressed and eradicated and so forth. And there is in the current generation of young people some desire, I think, in general, to overcome injustice. Okay, and it has inserted itself into the gender conversation because there is this kind of expectation that, particularly for, I'm going to say, males, that men have caused all the problems of human history. So they're to blame for everything. And more particularly white men, okay, are to blame for colonialism and slavery and oppression. And so even though there was slavery of people of color in human history in many civilizations. But there's this idea that the world can be divided up into the oppressed and the oppressors. And this, to my way of thinking, is a false binary. It's just as unfortunate as thinking that, well, there can be no transgender people because there's only biological males and biological females. It's simplistic thinking that doesn't serve us well, it seems to me. So I have seen some biological males who are questioning their gender and think that they might be female, and they have adopted this kind of woke perspective. So they're, in a way, trying to get away from being male, because the males are the bad ones. So they don't want to be one of the bad ones. So if they're female, well, then they're in the oppressed group. So that's better than being in the oppressor group. So there is some bleeding into the thinking, and I think not everybody is quite aware of it. I think some of it is very covert and very unconscious, even, and unfortunate. So I'm concerned that we don't have enough critical thinking about everything in the United States.
But it might be a bit, I don't know, men that haven't had any operations but just dress as a woman can go into women's spaces and things like that. That's not a big problem in Norway, but it seems to be in...
Well, there's more publicity about it than I think the actual occurrence of it.
Okay.
But I've been a defender of women's places, and I'm not in favor of self-attestation, pure and simple. Like, I just decide one day I'm female and I can go in all female places, private as they might be, without any exception. It's an issue that...
And in female sports, it seems like an issue.
I mean, it comes up in every institution. It's coming up in schools. It's coming up in prisons. It's coming up in sports. And I'm not going to solve these problems. And I don't presume to have solutions to all of them either. My focus has been on supporting trans identities and providing for transgender people what they need, whatever their age, wherever they are in their gender journey, and wherever they find themselves in whatever institutions. So I'm concerned about some of these issues. I think, as you heard me say yesterday, I keep wanting to say the other day. The other day was yesterday. There are a lot of people in America who think preposterous things, who think they can just decide what's true, and they can insist on other people accepting whatever they say is true. And the fact is, institutions operate in the way that they do, and an individual cannot, by force of will or by some kind of call for justice, demand that the world change around them. It's interesting because 20, 25 years ago, I never saw that. I mean, the trans people who were around then presumed that they had to change to basically adapt to the society as it was. So there was a lot of questions about passing, about being accepted in your affirmed gender, but it wasn't about like the rest of the world conforming to the trans person's expectation. And as we know from evolutionary psychology, the brain of humans is hardwired to detect threat in the world, in their environment. And when we encounter as one human to another human, our very first reaction is this person a threat to us or not? And very quickly on is the reaction, what gender are they? And the two are not unrelated, because historically in human civilization, male people are more threatening than female people.
Yeah,
so
you're stronger than I am. I can't. I have to pretend to be dead to survive. No,
I hope not. But,
but that's the thing, though, because I could never have a boxing match with a male. Like even like if I work out 10 times as much, I would still don't have any chance.
No, the only way you could hope to compete is if you took testosterone, which is a performance-enhancing drug, which is prohibited in most athletic arenas. And
but still, if I haven't gone through male puberty,
right.
I would still have smaller lungs and limbs and everything.
Yeah. So I again, yesterday you heard me say I acknowledge the reality of the biology of sex. So for someone who has gone through puberty as a male, as biological male, there are certain physical advantages that person has over someone who is biologically female and has gone through female puberty. So, but some people in the ideologically driven world think that simple declaration of identity equates with biology, and it's nonsense. It is not true.
Yeah, and trans females that have menstrual cramps and
which
like,
I said that. Yeah. It's like, no, you're crazy. You don't have that.
No, but the problem is that there is a lot of crazy people in America.
Yeah.
You've seen them on social
You
media.
think?
Yeah. Well, I don't think there's as many here in Norway, but I don't know. But maybe we don't see them. But So and that's might also be a bit. What you call it? They ruin things for those who are not crazy.
Yes. Well, I have been very public about me saying, and I'm not alone, that some trans advocates have just gone too far, and they've presumed that they could cause change in ways that don't make any sense, and set back the cause for which they're advocating of trans acceptance. And there are some notables in the United States who are on social media who are now pretty routinely calling out, like I do, calling out the kind of the crazy ones, and saying, no, you don't do that. You're causing problems for everybody. I mean, we're as we sit in this conversation, Tuesday, the very next Tuesday, which is 3 or 4 days from now, there's going to be an election in the United States for president.
Yeah.
And I think most people in Europe know this is happening. And much to my surprise and even my dismay, trans issues are very much discussed in the presidential discussions every day. Like, why? Like, well, because there've been so many controversies stirred up, and agitation from some for rights that go beyond acceptance and inclusion, and essentially presume that trans people should have privileges that other people don't have. I don't agree with that. It's like, in my case, I want to be treated as a woman. I want to be able to navigate women's spaces. I'm very respectful. I know who I am, here's an example. This is a bit inflammatory, and then we're needing to kind of come to our time for today, I think, if I may say that. So I have a patient that I've been working with who's an adult trans woman. She's very well educated. She's actually a manager in a management position in a technology company, California. Happens also to be a lawyer, so she's very smart. She's transitioned, and I'm helping her. She has a trans woman friend, okay, who is also transitioned. They have not had genital surgery. They've not had vaginoplasty. But the friend, not my patient, the friend presumes to go into saunas and other facilities.
With her penis.
Mm-hmm. Yes. And thinks it's the problem of the other women that she shouldn't be able to be there. And I'm thinking, are you completely nuts?
Yeah.
You're nuts. Like, that's...
I would not have like that. Like, well, it depends though, because in Norway we have saunas together with males, but then there's more males and there's a lot of males and females, but then it's open for everyone, and that's what you expect when you walk in. But if I had expect to walk in a sauna with only women,
yeah,
and someone has a penis, I would be a bit, that's a bit strange.
Yeah, yeah. So I said this yesterday. I said, there's...
And some people can be scared.
Of course.
Yeah.
And I understand that. I totally understand it. So there are some trans women who say, they're fully a woman, and they can have a penis and all that. What they fail to concede is the problems for other people with that set of beliefs. It doesn't entitle them, in my opinion.
I find it a bit egocentric.
No kidding. Yeah, absolutely narcissistic. And it's like, that sets back the acceptance, I think, of trans women to push it too far. Yeah. To push it too far. And that's that and if you back it up to young people, some of these expectations are infiltrating the conversation among gender questioning kids, where they get the idea that they can do whatever they want. They can have whatever pronouns they want. They can, have whatever expectations they want, and everybody else should just fall in line and accept it. And that doesn't seem appropriate to me. And in the conversation I have with my colleagues and, the luminaries in the field, the names we've mentioned a little bit today. So they are trying to balance acceptance and inclusion with common sense and a devotion to evidence and science. And I am too. That is my MO. And so I pretty regularly am saying, no, you're going too far. Don't do that.
Yeah. Yeah. And yesterday at the conference, I found it that way, that people are using common sense
Mm-hmm.
and are looking at the evidence
Mm-hmm.
and are trying to figure out different solutions for
Yeah.
problems
Yeah.
instead of looking for
Yeah.
new problems
Yeah.
or make up
we
problems.
have to do
Yeah.
it. So there was a flurry of controversy in Scotland in the last year or two where because Scotland had tried to create a provision in their law for changing gender marker by simple self-attestation. So just show up and say, no, I want female on my passport now, and I want all my documents to be female. And this was particularly provoked in a way by the fact that someone who had been historically male had committed a murder and been sentenced to prison, and was between the crime and the sentencing asserting a trans female identity, and so insisted on being incarcerated in a women's prison, and the authorities accommodated that,
Really?
and they were placed in a women's prison for about 2 weeks.
That's,
and there was
strange.
such a hue and cry about it
Yeah.
that they changed the person was sent to a men's prison. They had not had any surgeries, had not actually had, I don't think, hormones or much in the way of medical transition. So this
But does that happen in America as well?
it is happening in America.
Yeah.
And there it's at least as controversial in America as it was in Scotland. So the first minister, I think that's how it's referred to in the United Kingdom, because it's Scotland, Wales, England, and North Ireland. So Scotland has its own governance of a sort, but the national government is the United Kingdom, and the passport is United Kingdom. British passport is United Kingdom. So the federal government in London said, no, we're not going to allow that. We're not going to allow you to just change the passport because somebody wants to change the passport. No, there has to be some provision for reasonable qualification.
Yeah. But I think that you don't have to take all the surgeries to change gender.
Correct. Not
in your
anymore.
Passport. Yeah.
Not anymore. And I think actually in Norway, I think you can change your gender by.
Yeah.
Yeah. And I'm basically okay with that, but there has to be some kind of common sense balance.
Yeah, when it comes to safety and things like that for women, because we've been working hard for many years to be accepted and to have safe spaces for us. So yeah. Okay, but we've been talking for a long time now. It's been long days for you with the conference and with all of the discussions and things. But is there anything more you would like to say now?
No, I hope that as you supply your podcast to other people in Norway, Scandinavia, and throughout the world, that people will think about these things, and I urge them to be compassionate and rational.
Yeah.
And in society we have to balance many interests, of course. And I continue to advocate for the acceptance of trans people and for what they need. But we have to work together to meet those needs.
Yeah. And we have to make sure that kids get the treatment,
we do.
the right treatment, and that we don't actually harm them more than we help them.
Yes, we want children to get what they need at the right time, and what they need, not necessarily what they want.
Exactly.
Because children want lots of things
that they can't have.
They want ice cream 3 meals a day.
Yeah.
But that's not what we're going to give them.
No. And sometimes I think it's even kids need boundaries.
Yes.
They need that we who are grown up tells them that no, that's not how the world works.
That's right.
And if everything floats, then they can be really scared. Then everything is they don't have any control of anything, and they can see that we as grown-ups don't either if we don't help them to like, okay, no, you can't have that, and and that's not for you. You can be yourself. You can play with dolls even though you're like you have a penis. Like that's okay. And so that's what I'm concerned about. That we actually, instead of expanding the gender norms, that we in a way almost like
well at the risk of prolonging our long conversation, I've been concerned for some time that in the zeal to promote the interests of trans people, that somehow we have reverted to sexual stereotypes.
Exactly.
And this is not good. This is the wrong direction. We need to be more inclusive and more accepting. And which doesn't mean giving, as you said, not giving everybody everything that they want, but to be more accepting means balancing interests, and certainly for young people, we need to balance the interests of young people in terms of what they want with what they need, and parents are in a better position in some cases to determine what a child needs than the child themselves. And to my chagrin, in America, there are some people, child advocates, who say, but children know who they are, so just give them what they want.
Yeah.
And I often ask myself, have you ever been a parent? Have you ever actually had children? Do you understand what children do? It's like...
They say a lot of crazy shit.
Yeah, they do.
Yeah. Okay. But, thank you so much for coming here to...
You're welcome.
In English, it's Talk with Silje, or it's...
Talk with Silje.
Chat with Silje.
Yeah, Silje. How you say it in Norwegian?
Snakk med Silje. That's the Norwegian name. Snakk.
Snakk.
It means chat or talk. Yeah.
Okay.
Thank you for coming.
You're welcome.